gives me great pleasure to introduce Val Morrison, who was a former chair of SDF in the 90s for her sins, and she's going to talk about some of that now. So the floor is yours, Val. Thanks.
So then I became chair of the SDF. And, you know, to kind of head to the slides, you don't need to be Einstein to know that it's not a new problem that we're dealing with. We're asking a lot of questions about drug use from different perspectives. And Einstein also said that you can't solve the problems that you have with the same thinking, perhaps, that you used when you created them. And as a psychologist, I guess what we are learning is that we have to move from just a focus on the individual to the context in which the individual operates. So the kind of in the 80s, when I was starting out in my kind of research life, we had these amazing campaigns that were targeted at everybody. They weren't tailored. So Heroin Screws You Out was going out as these kind of mass media campaigns down south in England. In Scotland, we had a more positive framing of our message. So choose life, not drugs. But they were going out everywhere. And if you were a non-user and you saw these campaigns, you'd say, yeah, drugs are stupid. You know, I'm not going to do that. It would reinforce your non-use. But if you were a user and you saw that, then you would be kind of like, yeah, okay, but how am I meant to get myself unscrewed? What do you mean choose life, not drugs? I remember one guy in Junction Street in Jackie's unit saying, yeah, but life down here is drugs. So these messages did not resonate with the people that they were targeting, because they were targeting very generic populations. They weren't thinking about who are we actually trying to address here and how should we frame them, depending on your audience. This choose life, not drugs thing also kind of sent me off on this question about, is it a matter of choice? You know, do drug users have choice? Well, a colleague, a professor of addictive behaviours in Bangor, Miles Cox, he wrote that in the sense of having complete freedom from being determined by any causal factors, we believe that there's no such thing as free will. But if you define choice as an ability to make choices from amongst multiple options, even though the choices are governed by kind of natural processes, addicted individuals are free to choose. Although it might appear that they're unable to make this kind of free will, addictive behaviours are ultimately always goal-directed and voluntary, which I think is quite a tough statement. They go on to say that repeated substance use itself risks physical, emotional, and social changes that may weight decision processes against the cessation of use. So even when an addict recognizes that cessation would carry benefits, they possibly will not make that choice. So it's against this backdrop of, you know, who has the choice? Where are the choices? Is it possible to say that? That I guess I started foraging back through the archive. So in '96, the Right Honourable Michael Forsyth, the then Home Secretary for Scotland, announced that there was going to be this new initiative. And Dave Liddell? I've always said Liddell, yeah. Wrote a letter basically saying, you know, I have this organisation and I think if there's going to be this initiative, it would be really useful if the steering group of this initiative, that was an all-party thing, had appropriate representation from different organisations. So the Scottish Advisory Committee, yes, and the drug action team should be involved if this is going to work. It recognised this, he suggested they should recognise that these organisations work in different ways, that they're not all the same, but in order for them to be useful, they would, you know, cooperate closely with the initiative, and that would be helpful in making this campaign they were advertising work. The initiative should focus on prevention in its widest sense, and it should allow for the creation of user, personal experience informed, worker informed, credible, non-shock horror messaging that should be developed in consultation. And it should also, he recommended, consider the difference between dependent drug users and recreational users and not lump everybody into the same bucket. Following that letter, SDF was invited. They obviously thought, okay, yeah, invited to join the Advisory Council. The acronym Scotland Against Drugs didn't take us long to realise it spelt sad, but that was the acronym for it. And it had a very wide-ranging membership. It included SDF, obviously, politicians, it included the church, it included drug action teams, the police, also businesses that had thought of possibility of offering alternatives to drugs through apprenticeship schemes, etc., etc. And then they had this big media lunch. It was very nice, very posh. I was there because I was SDF chair at the time. The launch was delayed a little bit because of Dunblane, so they had this initial launch and then it actually didn't get going until July '96. And in the minutes of the launch meeting, the director of the campaign said that there is evidence pointing to 3 approaches with evidence of success, that if we combine them, we should have a synergistic effect. And that was the provision of alternative activities for young people, so sport, etc., education, including peer-led, targeted, credible, and novel initiatives. And the third thing that they pointed that there was evidence for was harm reduction and harm minimization. Dave McCauley, the then director, actually said, if we cannot embrace harm minimization, harm reduction, then we guarantee the maximum damage from drug misuse, lose a sizable proportion of our audience, and with them, the uniting component of the campaign. And behind the scenes, we were already, I was, I think, the only female there, with Michael Forsyth and Alex Salmond and George Robertson, men in suits, even Dave wore a suit. And I kept saying about the research evidence, but anyway. So already we were having kind of battles behind the scenes, but it did sound promising. They promised a step change, a tailored, etc. approach. We then got this kind of advertising that they called maverick advertising. It was meant to be exciting and different and new and credible. And so we had Michael Forsyth going around in a bus wearing his baseball cap backwards because he thought that got him down with the kids. We then had lots of short video adverts. We had things like Know Your Dealer and a man talking very, very close up to the camera in a rave, laughing about the fact that he was getting rid of vitamin tablets and aspirin, and these people, my buyers, have no clue what they're buying, they don't care. So don't trust your dealer. There was one about cocaine use and a guy splitting in half and rolling around the floor on the nightclub and his friends laughing at him, saying your friends won't be there to help if you need them type thing. There was a disturbing one with a photograph called a Polaroid, kind of Instamatic thing, where somebody morphed into a kind of monstrous, spotty, bloody rotting teeth character. And then there was a poster campaign, what do you call kids who take drugs? ... The majority. Now that message was meant to trigger parents to talk to their kids because maybe even your kid is using drugs. What it does from a psychology behavior change point of view is it suggests that drugs are normative, that everyone's doing it, therefore I'm not unusual. If everyone's doing it, it's kind of, maybe it's kind of okay. So these were their campaigns. I question whether they're not scaremongering, some of them. And then we had a lot of media attention about the buses, the trains with signs on them, good educational interventions in schools. People were going and opening up the subject and talking in schools. Local papers in Inverness were talking about it, Falkirk. It got away from this is just a city problem to the rural communities. Andy Fox, that was a great blast from the past. I went to my first boxing match ever, before or since, to raise funds for drug campaigns in Kilmarnock with Andy Fox. So we had lots of media attention. And it had £1 million, I think it had to run. And then a year later, 12 months in, there was all sorts of backlash going on in the press. The director publicly challenged the church for putting out suggestions of decriminalisation. He really challenged the harm reduction approach and those who peddled the myth that drugs are safe. And he publicly challenged those who were non-judgmental. He thought these were supporting drug users. I think we were called the happy clappy hippie lot or something in one paper. The harm reduction approach was really pulled up as conflicting with education and just say no type approaches. So he kind of went against what they had originally claimed to do. And around the same time, we obviously went to the same Google page, got train spotting poster. Around the same time, we had this going on. And initially, it was a little bit conflicted in the media. Initially it was gritty portrayal of realism that might glamorize drug use, but then it became viewed as one of the biggest anti-drug messages ever put out there. So interesting times indeed. The Glasgow Carlton Athletic Group were actually very much involved in the making of this film. Interesting, you also referred to Carlton. When I look at then and now, I mean, when I was out in the streets in Edinburgh, it was very much about Edinburgh, it was very much about injecting, it was very much about AIDS crossing the Atlantic, and it was about polydrug use, temgesics, temazepam, DFs, that kind of multiple drug use culture. And I look now, and I see, maybe Dundee's got more the problem at the moment, and the drugs of choice seem to be reasonably similar. Benzos, opiates, psychostimulants, stimulants. The concerns about infection seem still to be there. But the approaches, from my view, as an outsider kind of looking in now, they do seem to be more varied, and there seems to be more choice available now than there seemed to be in the early days. And then I read some newspaper coverage and I wondered when this was. And experts were pointing out that methadone is recognized by the WHO, essential medicine, but they say it's not always delivered effectively. Dave Liddell of the Scottish Drugs Forum says there's a massive issue around people on too low doses of methadone, estimating about half are on too low doses. So what's happening is that they're going to top up on street drugs, which is fueling a polydrug use concern. And I thought, oh, this is an old article. I remember Dave saying this, thinking it was 1990. It was July 2021, which really, I thought, wow, And then I looked back at some papers, and the Daily Record's always been a great fan of the big headline. So, the Daily Record here, these were in 2019. So I kind of thought, well, what has changed? We still have stigma, without a shadow of a doubt. UK Drug Policy Commission, this is now 10 years old or more, but they did a large survey of people's perceptions of drug users. And you had quite kind of positive things. We have a responsibility to provide the best possible care for people with drug dependence. We have over half agreeing that we need to adopt a more tolerant attitude towards people with a history of drug dependence. We have a majority, 80-odd%, saying that virtually anyone can become dependent on drugs. But in the same survey, half of the sample said people with a history of drug dependence are a burden on society, and almost half said, I don't want to live next door to somebody with a drug problem. So in one way, we have the kind of positive, and in the other, we have this stigma. So to change behaviour, what can we do? And we have to think about what behaviour is it that we're trying to change anyway. Are we trying to change behaviour? It's the first question, I guess. And one model, we psychologists like our models, one model that's achieved a lot of research support and has moved in from research into implementation science, and I look forward to hearing what a colleague says about this later, is the COM-B model. So this says in order to understand behaviour, we have to look at people's capabilities, opportunities, and motivations. It recognises that there are dynamic and very, very complex determinants of human behaviour. We are actually quite complex people. and that increasing motivation, physical and psychological capability, and providing social opportunity is what is required to change behaviour. And it does so in a range of ways. It could be education, it could be modelling, transitioning over into real life practice. It also looks at things like setting goals, looking at life values, looking at what do you want from life, that kind of thing. I don't have time to go into the detail of it, but there's masses of papers on it. And it also says that we need to specify the target behaviour. Sounds obvious, but in the first instance, are we talking about Class A use, injecting use, social use, recreational use, whatever? We need to identify what needs to change. Is it the type of use? Is it the frequency of use? Is it confidence in stopping use? What are we trying to change? And what is the behaviour that we want to change? They offer all sorts of examples of ways of changing behaviour, evidence-based ways of changing behaviour, where your intervention would be different if you are trying to target lack of insight into the risks of drug use, for example, as opposed to if you're trying to target lack of confidence in being able to change. So it's all very kind of mapped out. And in the grey, they acknowledge that all of this is happening in a context, in a policy context, that will support different intervention functions, so individuals in the centre. An easy-to-read sample of school-based users, this just kind of gives you the kind of example. So increasing awareness about norms, reflecting on your own patterns of behaviour, that kind of thing. Maximising self-regulatory capacity. So how do you deal with stress? How do you deal with negative emotions? How do you deal with challenges? How do you deal with sadness? How do you regulate your emotions? Increasing life resilience skills. How do you communicate about your situation? How confident are you? And then things like contextual change, what's your availability of social support, etc. Easy to read sample. Subjective social norms, we talk about peers and the role of peers. Well, actually, it's not just a standard thing that everyone's influenced by their peers. Certainly late adolescents are less amenable to peer-based interventions than the younger adolescents. Late adolescents develop more around kind of individuation and being different. So, we have this idea about targeting people's peers and their perception of norms, but it might have a different kind of age relevance. Also, we talk about control. Control is slightly more generic across all of us. We like to feel we have some element of control over some aspects of what we do. So it might be, I can take drugs if I want to. No one's going to tell me what I'm going to do. It's up to me. I can stop when I want. I don't take as much as X, Y, and Z. I'll be okay. But it is also about control over being able to stop. I feel I can do what is required to stop or to change or to reduce, even if my friends still do, even if I find it hard. So perceived behavioural control is something we look at a lot in interventions. But what are the less easy targets? So this is the picture of some of my friends from my bus project, my first job after graduating from quite stuffy St Andrews to working with the homeless of Cambridge. And these lads and lasses were punks, they were homeless, they were taking glue and amphetamines in the two on the top left. The guy on the bottom left was a former academic who'd had a mental health breakdown, who was a drinker. So he was a drinker. On the top right, two Irish, Mickey, Joe and Patsy. They were just wonderful guys. They defended my ears against bad language. They thought I couldn't listen to, so they used to really protect me. But they were meth drinkers, jakey drinkers, and they dabbled sometimes when they got glue from their punk young punk friends on the bus. And then Keith on the bottom, he was also an ex-academic, but he was on meths, alcohol, and amphetamines and could turn on a pin. But how do we reach these targets? How do we reach these homeless people? It's all very well doing surveys of people who are already in contact with services. How do we reach these? And that's always, I think, been an important question for me. Asking people why they do things will depend on when you ask them, but these are just from a very early paper in 91, when we were asking users to think back to what motivated them to start, what motivated them to switch to different drugs, what motivated them to stop. And so in terms of initiation, in the highlights, you get, because my friends were, because my boyfriend was, I was curious, I wanted to try something different. In terms of switching to a different drug, I mean, the one person says, I took DFs because I wanted to see exactly what kind of stone I'd get off them. That young lad was Leith, Banana Flats. He died aged 20. He was found several weeks after. He was a great lad. Lying in front of a fire in his flat. Horrible death. But that was just what he had grown up with. That's just what he did. But my God, his mental arithmetic was good. On a different path, he would have been an accountant. Amazing. Anyway, some of these stories bring back lots of memories. So curiosity is certainly there at the initiation. Wanting to try something different is there for switching. For stopping, having bigger prison sentences was certainly cited as a reason for being a little bit more careful, and having availability on the market also. So kind of more external. So my final slide. Looking back on all of this has been really interesting, I guess, for me to kind of ask, so what has changed, what still needs to change? We certainly need to recognize individual differences in capability, in motivation, and in opportunity, because opportunities are not the same. I'm teaching, what's the expression? Grandparents to suck eggs. You know this. But do our campaigns, do our services fully recognize these differences, or could they do more in recognizing the individual differences? Certainly talking to the funders of a lot of our mass media type campaigns, or our government-led often campaigns, certainly we shouldn't expect one size to fit all. Credibility of messaging is really important. How can people achieve their valued goals? How can we support people finding what their goals are, and how can they achieve them? And we need opportunities, preventative services, etc., etc. And we need funding. Things seem to have got better in Scotland. I mean, I live in Wales now. I think things are different in Wales, perhaps, than they are into Scotland. My final thought, given why we're here, really, is that we need an organisation that represents the voices of the sector in all its various shapes and forms, that is not reluctant to use the evidence base from people sometimes thought to be sitting in ivory towers, but actually use the research evidence base to inform practice, to inform training, to work with policymakers, to work with practitioners. And so I think I'm really, really pleased that although we're losing Dave, I'm really, really pleased that we're not losing the SDF. And thanks for letting me come and share in this day with you.